Substance abuse, medical management of alcohol effects and withdrawal. There is a medical view of alcohol misuse, and there are behavioral aspects. The actual medical diagnosis pertaining to alcohol is either alcohol use disorder or alcohol intoxication. Older terms like alcohol abuse or alcohol dependence are no longer used as diagnoses, but they are still used to describe the criteria for reaching the diagnosis of alcohol use disorder. Society still uses terms alcoholic and alcoholism, and there is considerable resistance to the idea that alcoholism is a medical disease because in reality, alcoholism is not just a disease. These slides will cover the medical model of alcohol use disorder, intoxication, and alcohol withdrawal. But the student should assume that the person also needs other therapeutic interventions to maintain sobriety. After all, alcohol abuse is a behavior that affects mood, relationships, social role function, and family dynamics. There are dose-related effects of alcohol on the brain. Alcohol gradually shuts down vital functions of the brain in a dose-dependent manner. Lower doses start by shutting down the ability to make effective decisions and make it more difficult to coordinate your physical movement. More alcohol will affect the midbrain, causing a depressed mood and impaired memory. This is the mechanism by which some people have a blackout for events during their intoxication. And eventually the brainstem will come under attack and the vital functions of the brain may fail and cause death. Blood alcohol levels are expressed as a percent. The actual calculation of this number is complex, and I would not expect you to know how to do it. Instead, understand that the number represents the amount of alcohol in the bloodstream that is measured by grams of alcohol per deciliter of blood. This slide illustrates the progression of brain damage that comes with progressively larger amounts of alcohol in the blood. It's important to note that these numbers are for the normal alcohol-naive person. 0.05% is poor judgment, 0.1% slowed reaction time, 0.2% abnormal behavior and crying, 0.3% double vision, 0.45% unconsciousness, and 0.65% will result in death. Due to the ability of the body to adjust to chronic alcohol use, tolerance will develop over time, and a person with alcohol use disorder may not show any signs of intoxication with relatively high levels of blood alcohol. Emergency room nurses regularly see people who look perfectly sober with a blood alcohol level of 0.5 and higher. This is the result of tolerance to the alcohol. As an aside, I would like to comment that the chronic alcohol user will not be the person pulled over for driving under the influence. Instead, binge drinking is the major contributor to impaired driving accidents that occur. I do not expect you to study or remember any specifics off this chart. I include it to give you a reference you can use to estimate the risks involved with rapid consumption of alcohol. As you read the chart, I would like you to notice there are gender differences. Your text uses a different measure called the serum ethanol level instead of the blood alcohol level used in the previous slides. The blood alcohol level is reported in grams per deciliter, and the serum ethanol levels shows milligrams per deciliter. Moving the decimal point will convert one number to the other. Therefore, you probably know that the legal blood alcohol limit for driving is 0.08. In the text, that number is 80. Now let's look at the medical management of alcohol toxicity. Unfortunately, there are no treatments that quickly reverse the effects of alcohol. The treatment for toxicity is to manage the symptoms. Simply put, the liver has got to break down and detoxify the alcohol still in the blood. Your job is to make sure the patient doesn't die in the process. As noted here, you will need to assist with breathing, maintain the body temperature, treat any hypoglycemia, and correct electrolytes as needed. The administration of medications to cause vomiting is not recommended because of the rapid onset of CNS depression and the risk of aspiration. The administration of activated charcoal is not recommended because it does not bind to alcohol. Forced diuresis is not helpful because only 10% of the ethanol load is secreted in the urine, and 90% of the ethanol metabolism occurs in the liver. GABA receptor antagonists such as naloxone and flumazenil have little effect on the CNS or respiratory depression caused by ethanol. Their use is not recommended. The effects of insulin, glucose, caffeine, and several other medications have been studied, but none consistently increases ethanol metabolism or alleviate CNS depression. As a last resort, hemodialysis effectively clears ethanol from the blood. It is saved for last because it is an invasive procedure and introduces new risks. In addition to the depressant effects on the central nervous system, there is an activation of the pleasure pathway in the brain. Recently, the exact pathway in the brain has been mapped in rats, and we now know that stimulation of glutamate neurons in the dorsal raphe nucleus region of the midbrain leads to activation of dopamine-containing neurons in the brain's reward circuit. The brain shrinks over time due to alcohol toxicity and vitamin deficiencies. This MRI of the brain of a drinker shows the dark shadows of enlarged ventricles caused by shrinking gray matter. This damage will result in a specific pattern of alcohol dementia called Wernicke-Korsakoff syndrome. Wernicke encephalopathy develops in those people who develop a thiamine deficiency with prolonged alcohol abuse. The reason for this deficiency is twofold. Alcohol suppresses the appetite, and the diet is deficient in vitamin B. The other reason is the effect of alcohol on the mucous membranes of the stomach and intestines, causing a malabsorption of vital nutrients. Korsakoff syndrome is what develops out of Wernicke encephalopathy, and for clarity, I list the symptoms of each separately, but you will not be tested on the difference. Instead, it is sufficient that you understand that long-term alcohol use can result in this profound dementia. This individual obviously requires skilled nursing care. Medical treatment of Wernicke-Korsakoff syndrome focuses on prevention. As a nurse, you will become well acquainted with the banana bag. The yellow color comes from the multivitamin component of this solution. Just about every person who is admitted to the hospital with a history of alcohol use will have one of these ordered. The typical composition of a banana bag is 1 liter of normal saline infused with thiamine, folic acid, magnesium sulfate, and a multivitamin. I will not ask you to know the many organs of the body affected by alcohol, but there are 3 major organs that sustain the most damage for obvious reasons: the GI tract, the liver, and the pancreas. Vomiting bright red blood is most often a result of alcohol abuse. Through antiquity, it's been common knowledge that alcohol can kill, but it was not always clear that alcohol withdrawal could be just as dangerous. This graph is a rough comparison of the physical harm caused by a drug of abuse and the physiological dependence produced by each drug. With dependence, a person cannot feel normal without the alcohol. long beyond the time when their blood alcohol comes down to zero, the body is physiologically speeding with oversensitive glutamate receptors. This leads to the jitters and an actual ache for a drink. Addiction does not cause withdrawal. Dependence causes withdrawal. The psychological and emotional longing for the drug drives an addiction cycle of use that is difficult to resist. In contrast, the person dependent on alcohol is literally living in a body that can fall to its death if the drug is not supplied. The brain has been chemically altered to require alcohol to maintain normality. With the help of a prolonged time in sobriety, the brain will re-regulate the GABA and glutamate balance, and the neurons will heal, but it can take up to 2 years for the brain to recover from the damage caused by excessive use. This slide explains the relationship of GABA, alcohol, and glutamate. As long as alcohol is in the body, it fortifies the inhibitory effects of GABA in the brain. Over time, the brain strengthens the glutamate response to bring the brain back into balance. That balance allows most people with chronic alcoholism to appear sober. They look normal because the brain has compensated. Once alcohol is withdrawn, the enhanced glutamate overstimulates the brain, resulting in the signs and symptoms of withdrawal. Alcohol withdrawal starts when the blood alcohol level goes lower than the body can tolerate in its dependent state. The blood alcohol does not have to approach 0%. Therefore, monitoring blood alcohol levels over time is not useful information to the clinician. What is important is knowing the time of the last drink, because 24 to 48 hours seems to be a peak time for withdrawal. But, as the graph illustrates, it's impossible to predict the actual onset or severity of withdrawal. Therefore, nurses need to stay alert for any acute changes in patient condition from the moment of admission until discharge. The medical goals for treating alcohol abuse are also goals for the nursing care. This presentation will cover medical interventions. The nursing interventions that go with these are in the text. Reducing immediate withdrawal symptoms, preventing complications such as death, and beginning to promote alcohol abstinence. Where is detox? Most people attempting to abstain from alcohol will detoxify outpatient with or without medical assistance. Inpatient detoxification is indicated if the person is at risk for severe symptoms or those with major risk factors like pregnancy, major medical or psychiatric diagnoses, multiple previous detoxifications, or prior history of physical withdrawal syndrome or inpatient detoxification is indicated if seizures or DTs appear at any time in the first week of abstinence. Before we had the benzodiazepines, alcohol detoxification had to be done with alcohol. The problem is that the body cannot counteract the excitatory glutamate without the help of the drug. Gradually reducing the amount of medication over time is the only way we can prevent seizures or death. The choice of drug is up to the physician's preferences. Diazepam and chlordiazepoxide have a longer half-life, so they do not have to be taken as frequently as the shorter-acting medications. The liver breaks these medications down, and the longer-acting medications are not a good choice in patients with pre-existing liver disease. In this case, lorazepam, and oxazepam are used. You may also find physicians will use anticonvulsants and beta blockers to treat the physical symptoms and the antipsychotics to treat any psychotic symptoms. Once the danger of detoxification is past, it is time to assist the patient with cravings and other triggers that may cause a relapse into alcohol use. At this time, there are 3 major medications that promote sobriety, each with a different action. Disulfiram is a very old-fashioned medication that is not often used. However, there are some patients who believe that it is helpful and are willing to accept the effects of this medication. The medication blocks the enzyme that breaks down the most toxic byproducts of alcohol metabolism, acetaldehyde. If you have ever had enough alcohol to throw up or experience a horrible hangover, you know what acetaldehyde does to the body. This medication is a form of behavioral modification. Instead of experiencing the pleasure in drinking, the repeated experience of feeling terribly ill will eventually cause the person to anticipate illness instead of pleasure when they see a drink. This negative association will change the behavior over time. This works for some, but when it was the only medication available, habitual drinkers learned exactly how long after their last pill they could have a drink without getting ill. As you can imagine, that defeated the purpose of the drug. Naltrexone is a medication you already know. It is used to reverse the effect of the opioids in occupying the receptors as in this picture. These receptors are responsible for the reward from alcohol. The end result is that the drink does not produce the usual reward. And if the person increases their intake to get to the high, they feel sick and never achieve that reward. It does not reduce cravings. This medication is also a form of behavioral modification. By preventing the reward over time, the person stops associating alcohol with pleasure, and they gradually just stop turning to alcohol. Unfortunately, physicians and patients often misunderstand this medication. For it to work properly, the patient has to have multiple relapses while continuing to take the naltrexone along with the alcohol. Thus, it's a problem if the patient or physician gives up on the medication instead of staying with it long enough to achieve the behavioral change. Acamprosate works as an GABA agonist. By this, I mean that it works to restore the balance in the system that is heavy with glutamate, the excitatory neurotransmitter. To show how it helps with the cravings left over after detox, I've added one more slide to the scale I used earlier. Excess glutamate does not in itself cause cravings. However, the discomfort of the imbalance will produce a dis-easy feeling that is experienced as nervousness. Research into alcohol cravings has been complicated by the fact that the symptom is subjective. The urge to drink is variably described as a physical need by some and an unconscious yearning for a return to the reward state by others. Those with the physical need type craving report that acamprosate stops their cravings and gives them a feeling of well-being. There is a lot more to know about alcohol. This graphic is difficult to see in PowerPoint, so I have the website available for you to see the original. This is not content on the test. I just wanted to conclude this presentation with a visual that emphasizes why all nurses need to know the basics about alcohol use. You can safely assume that anywhere from 25% to 80% of the inpatients you will care for have abused alcohol, and may need your expertise to save them from the preventable complications of alcohol ingestion. Thank you. This has been Carissa Enright, Associate Clinical Professor at Texas Women's University.